What up, what up, what up, everybody? Welcome, welcome, welcome to another episode of the Modern Medicine Podcast. I am your host, Dr. Dennis Tien. I am a graduate of Tufts Medical School, the Harvard School of Public Health, and a practicing primary care physician here in the Boston area. And this is the place to be to hear all the best news and information about what is happening in the world of medicine. I'm joined, as always, by my producer and the man himself, David Yaz. David, how are you doing today?
Fantastic, Dennis. It's great to be here and looking forward to the guest because you lined up a fantastic guest. Much better than just producer Dave sitting here on my butt.
We have a fantastic guest today. We are joined by Deb Schoenthaler, who is the Executive Director of Physician Performance, LLC, an accomplished healthcare executive, and just a ton of experience in healthcare, accountable care organizations, and all the machinations of what happens in our healthcare system, which is such a huge part of how we deliver care, really, because it's not just about the medicines and the technology and the science. It's a lot about the system, and we learn that again and again. So Deb we're going to bring her right in and start with her. Deb, how are you doing today? Welcome, and thank you so much for joining us.
Thank you so much for having me, Dennis. It's interesting. I liked your intro. I wish that medicine were all about the science and the taking care of people, but there's this unfortunate other side. And I spent most of my career, helping physicians manage that other side of the piece. So I don't know if it's helpful to give just a little background about me, just so you all understand kind of where my thoughts come from.
That was going to be my first question, so go for it.
Perfect. We are in sync. So I started out my career many years ago. I won't say how long, but I worked at Harvard Community Health Plan. And back in the day, that was the entity that managed their hallmark health centers. So people always think like the Kenmore Health Center near Fenway Park. But I specifically worked for the medical groups division. And that was a new division that focused on not these owned entities, but negotiating contracts with individual physician groups and how doctors could manage entire panels of patients on a capitated basis. And so for those who have never heard of that, that means that like your office would get a set amount of money every month. Didn't matter how many services those patients got, you would get a set amount every month for every person who chose you as their primary care provider. And so that work really, even though I was working on the insurance side, really led me to delve deep into how do physicians manage their practice. I learned about financial models and kind of how people operate. And we did a lot of reporting and monitoring and cost and utilization. And so I stayed at Harvard through the merger with Pilgrim Healthcare. And then I worked on a team to kind of take those two entities and push all those systems together. So I did a lot of work around financial modeling and supporting these new practices. And then a colleague who was working at the BI and Deaconess merger said, hey, you have a lot of experience. Why don't you come over and work for the providers? And so I've been doing that ever since for the past 20 plus years, really helping providers understand how to do well financially and operationally in healthcare contracts.
Yeah, I mean, it's important work, first of all, because the reality is the financial side of medicine is a huge part of medicine. That's just it. And, when we talk about primary care, and I would say even now for most specialists, right? And what's one thing we consistently hear from people? I can't find an appointment anywhere, right? Like that's a big problem now, access to care. And as someone that's practiced now for almost a dozen years, I would say accessibility is like 70 or 80% of the game in terms of delivery of good care. And accessibility is intimately tied to the finances behind it. So the work you do is critical.
So that leads into just talking about what physician performance is, and that might be helpful for your audience. So we have
it might be helpful for me too. Just kidding.
So we have about 3,000 physicians in our organization and still growing. And all of our physicians and practices join through one entity. We call them members or shareholders. And so for you, Dennis, you're part of an IPA called Affiliated Physicians, Inc.
Right.
And that is an entity that helps independent practices join larger organizations. And I think one thing that's very unique about physician performance is we are governed by our physicians. Every board member, every committee member is a physician who's part of the organization. And we make sure that our boards and committees have representation across all those members, so that we have an IPA up in the North Shore, near Anna Jake's. We have a representative from there on our board and on our committees. We have API, which is much more geographically diffuse. We make sure we have members from that organization who are on our board and committees. And I think that just, a really important element of our organization is that our tagline is empowering physicians, elevating healthcare. We focus every day on helping put physicians and practices in those positions to succeed. And so I know later you wanted to talk specifically about private practices. I just want to stay at like the highest level for our entire organization. The things that we focus on are governance support, helping our board and committee members, and I'm talking about like my staff, helping our board and committee members make sure they understand all the intricacies of the discussions they're going into at these boards and committees. I want you all to be practicing medicine, right? It's really important for our organization that it's governed by physicians, but I want that to be 10% of what you're thinking about, right? We have staff that go out and vet and investigate, like, what is that new DOI regulation around X, Y, or Z? I don't want any one of you thinking about that. And then we create summaries and say, here's the information you need to go into this meeting. So that's a big part of what we do.
And you work with physicians across multiple hospital organizations as well.
Exactly.
So my practice is affiliated with Beth Israel Lahey Performance Network, but you guys work with multiple groups.
So again, our physicians, because we're spread from the top of Massachusetts to the bottom, all the way down to Plymouth, we focus around and do a lot of work around physicians affiliated with hospitals. So we'll do work with all the docs who use BID Needham as their main hospital. And so we'll work with those primary care providers and those specialists to say, how are we all going to work together to provide the best possible care for our patients? And the issues there may be very different than the issues for the docs who are affiliated with and close by to BID Plymouth.
Right.
And those may be very different than the ones who use BIDMC as their main hospital. So we really try to tailor all our work to what is happening in those local communities, in those local geographies.
Can you give us some examples of some of the things you guys are working on right now to accomplish your mission?
Sure. So I guess I would mention a few things. One is we do a lot of advocacy around government policy issues. And so we were very vocal when telehealth changed after the more crisis of COVID was ebbing. The payers, and I know this was one of your questions that you sent me, the payers kind of took the view, I believe, that, well, COVID is winding down. We had these, and the state, we advocated for this, the state had these broad policies around telehealth coverage. They paid for them as if you were seeing that patient in your office. The payers took the perspective that, well, now that's all over with. And so you can continue to do telehealth, but we're going to pay you less than if you had seen the patient in your office. Now that works if you're a telehealth company and all you do is telehealth, right? You could say, well, the overhead of running this, I get, is not like the overhead you need to see patients in an office. So the rate would go down. But I believe what happens with the majority of our physicians, and you tell me if you disagree, you fit telehealth in with all the other patients you're seeing. It's a hybrid model. You see patients in an exam room, you go out, you do a telehealth visit, maybe in that same exam room, you still have the same overhead in your office. So there really is no logic for the health plans to make that correction. That's something that we're continuing to advocate for. There are some folks in the legislature at the state who agree with that and are trying to work to get telehealth to be bumped back up to that regular rate.
Yeah, I mean, one of the things I was going to bring up with telehealth was telehealth. So let's talk about telehealth because it's a big thing right now. And I think most practices are using telemedicine, and I certainly use it in my office. And, you know, for us, it's a game changer for a lot of reasons. It's a double-edged sword clinically. First of all, you have to be careful clinically because there are just some things that should not be managed on telehealth. The beauty of my office versus, say, a telehealth company like Amazon or something doing this stuff is if I get on the phone with or the video visit with a patient and I say, you know, I'm worried about, I need you to come into my office. I need this test done. I need to check your thyroid. I need to check your urine, whatever. I can have that person in the same day or the next day and do that test. You know, so clinically you have to be careful, but from the economics of running a practice, and I'm just going to be honest about this, is that there are there are so many challenges that private and even non-private practices face. The economics of running a medical office. It's why so many independent offices have gone away in the last 10 to 20 years. And telehealth is like one of the few carrots that I think we've gotten thrown to us, right? Where we can offer a service that is convenient, that is in many ways effective, that the patients like, because sometimes they don't have to come in for some things that they can just discuss on the phone. And we're allowed to bill for time that frankly we should have been able to bill for years ago. If I have someone in my office and I do a test on them and that test comes back with an abnormal result and I need to spend a 15 minutes discussion with that patient about that result and make a treatment plan and a further diagnosis and referrals and all that stuff, then rightfully so, I should be able to bill for that time. And telemedicine allows me to do that without having to drag the person into my office, okay, in the most effective way for them and for us as an office to operate efficiently. So it is one of the economic tools that we use in our office to stay afloat. So if we lost it, it would be devastating to us.
So I'll give you two examples that we talked a lot about during COVID and coming out of COVID when some of these changes were being brought forward by the payers. One is, so my daughter works an hourly job. If she gets sick, she has to leave her job, drive to wherever the doctor's office is, sit in the waiting room, have her visit, drive back to her job. So I don't know. At the best, that's an hour. At the most, it could be 4 hours, right?
Right.
If she could instead schedule a telehealth visit, take a 10 or 15-minute break, get on the phone with her doctor, now she's gotten taken care of. So that's a first example where, you know, we have all these patients who are trying to work and stay healthy.
Absolutely.
The second example I would give is the patient who is homebound for a number of reasons.
Yes.
It could be their own health, that it's difficult for them to get transportation, take the transportation they have. Maybe they take public transportation and it's difficult for them. Or they are the caretaker for someone in their home. And it's not, they maybe can get in their car, drive to their visit, but they can't leave their loved one alone. So they don't get their care, right? You must see this in your practice all the time. They just don't get their care.
We just had someone this week, right? 82-year-old guy with a BMI of 37, has a really hard time getting around, needed refills. We hadn't seen him in 8 months. I said, he's got to have a visit on the books. That's liability for us. That's not good care. If we don't have some kind of record that we're taking care of him, I can't get in there. It's too hard for me to get in. I got to arrange transportation. I got to this. I said, okay, let's do a telemedicine visit today. And then you can come in sometime in the next 6 weeks.
Well, and Dennis, I'm sure you did that in your office, in between seeing patients in person.
That's right.
So that again gets to that concept of it's a hybrid model. So you can't say there's less overhead in your office when you're doing that telehealth visit. There's not.
There's
There's
not. It's the
probably
same
more.
overhead. It's the
Right,
same overhead, if not more,
right,
100%. Yeah,
right,
it's
right.
it's a terrific modality. So, you know, I'm glad that you advocate for that, because I will say this: if telehealth completely went away, I mean, I mean, everyone thinks if you're a doctor, you're rich. And that's just not the reality of the situation anymore, especially if you're a primary care doctor. Notice to the world, there's a reason why all these primary care offices are going away and why it's so hard for everyone to find appointments. It's because primary care is not great business. You do it as a physician because you love it. You love your patients, right? You love the practice of medicine. You enjoy the challenge. You care about your patients. I can say that sincerely. That's the truth for me. You
And
know,
I think there's a lot of demands on primary care providers now, much more so than in the past.
there is.
Dennis, I will say one thing promising about telehealth is in the passing of the budget. You know, there's a lot of back and forth. What was going to go into the budget? What was going to go into, you know, some of these amendments? They did save telehealth for another 6 months.
I saw
And
that.
I think it's because, you know, especially now we're talking about CMS, so we're talking about seniors. All those issues we just talked about get bigger when you have a senior population, right? Not being able to get into the office, not being able to get transportation, being in a rural area where, you know, going to the doctor is like an all-day affair. So I feel like that was promising, but we need to keep the pressure on.
Absolutely. And if you guys need anyone to ever like come testify at any kind of hearings or advocacy at the State House or anything like that, please let me know, because I would love to get up there as a soldier on the front lines here and just kind of share how critical telemedicine is to both the clinical care we provide and the financial viability of primary care practices, which you cannot dismiss. Primary care needs to be financially viable for individuals to do it. And we need primary care. All of us do. So it's so important to make that. I want to shift gears a little and just talk about a different subject. Another thing that we use in my office, and I know you know this because you're helping us with the credentialing right now, is so-called mid-level providers. I know that term. Sometimes people don't like that term. So let's say nurse practitioners and physician assistants. More and more, we have a massive doctor shortage in this country, and it's really been the case for a long time. And I think it's getting worse as the population ages, the population grows. We become less healthy as a population, amazingly, in spite of our technology. The way we live is so unhealthy. We're getting less healthy, and we need doctors more and more. And yet there are proportionally less and less of them. The only way that void is going to get filled is with nurse practitioners and physician assistants for the next 10 to 20 years at least. What are your thoughts on how NPs and PAs can help fill the void and provide, you know, quality care to patients that need to be seen?
Yeah, I think it's wonderful that more and more offices are staffing with NPs and PAs. You know, I think that not only for the direct care that they're providing to patients, right, and offload from you, but, you know, they can do those telehealth visits. They can do those, you know, portal messages that you're getting from patients. And you can take, not that that's all that they should do, but then that allows you to have more free time to your point, talk to that morbidly obese patient that has tons of chronic diseases and needs like your physician level of care. So I think they're a really good part of the practice. Unfortunately, again, a place where advocacy from your physician organization will help. The health plans are moving to take that 15% reduction on fees. We just saw Harvard Pilgrim change their policy. We put it out in our newsletter this week, where they're going to pay those PAs and NPs 50, they're going to take the 15% discount. Now, that for many practices, it may change their decision, maybe not on having NPs and PAs, but how many they have, right? Because they need to be able to financially support that.
Yeah, I mean, I think that the care that NPs and PAs provide is terrific, first of all. And I do think they need to be supervised. Certainly younger ones and less experienced ones need supervision for sure. And I think, it's funny because like, obviously the state law requires them to have some level of supervision from a physician, but I'm no UC in what you do. And I certainly have seen in my career that supervision is loosely defined. Like sometimes the physician, like in my office, I'm there every day and I'm
Yep.
supervising. They tell every patient that walks through my office, if I either see them myself as well, or if I don't see them myself, we sit down and talk about it at the end of the day or during the day.
Right.
That's very hands-on. There are a lot of places where the supervising physician is at another location. They may have a couple hours a week. They may have a couple hours a month with them. They may not have much time at all with them. So I think it's important that they're supervised, but the care they provide, it can be a very effective care model.
Absolutely. I think this is the issues that you brought up. I think that there are counter arguments to that people would bring, and that's the discussion, Dennis, that needs to be had so that there's an easier path forward to saying this is how NPs and PAs are going to operate, whether it's the state of Massachusetts or it's a federal decision, but like there's no gray area anymore, and everyone understands what that's going to mean. So I think those discussions are going to be had soon. There's a primary care task force that was convened by the Health Policy Commission because they understand that healthcare in Massachusetts is in crisis with these access issues, not just for primary care, but for specialty care. But they're focusing on primary care because it is so difficult to find someone. And how do we build up that pipeline of physicians and of supports for physicians, which may be NPs and PAs. And if we do that, what are the rules around it? What does it really look like? And I think those are all important to flesh out and understand so everyone knows the model that they're working in.
Agreed. And I think it is a little bit of a gray area right now about how it all works. And, a lot of offices, both specialist and primary care, are moving to a model where every patient sees an NP or PA, and the attending is just kind of, picking which patients they're going to see based on clinical need. And that's kind of what we do, frankly, in my office, because look, if a 23-year-old comes in and it's a physical or a med refill, I might not need to see that person, but that 82-year-old
Right.
morbidly obese guy with heart failure and he's short of breath,
Right.
and we're deciding whether we're going to send him to the hospital, that's the one I need to spend a half hour with. So
Right.
the
Right.
NP-PA model allows me to do that. And also, I would say, have more time to follow up with patients, to call patients, to review results, to respond to emails, to get all the work done that makes our office go. Having those NPs and PAs by my side helping me is just invaluable. I think it's really what makes my office work well, frankly.
Yep. Yep. And it sounds like you are very in touch. You have a really close collaborative relationship with your staff. And I think that's the part that is key, right? That it's not sort of you're operating over here and they're operating over here. It's very collaborative.
It's very collaborative in my office. And it's one of the things that I'm not sure if I could grow much more. I'm scared to grow much more than I have because I don't want to lose that personal touch that I still have. I don't want to have an NP that has, an hour a week with me. And I don't know what's happening from patient to patient. I don't right now I have my hand on everything, and that makes me feel good about it.
Yep.
Let's talk before we wrap up, Deb. One more thing I want to talk about is about, because my office is a private practice, is an independent practice, as you know, and we're affiliated with Beth Israel Lahey. I want to talk about the viability of independent medical practices in the future of medicine and how you see that. I think we've certainly seen a lot of primary care independent practices go away in the last 10 to 20 years. It's really hard to find them. I can't tell you how many people come into my office and say, I used to see Dr. So-and-so for primary care, but they went concierge or they retired and are doing something else. What are you guys doing to support private practice? And what do you see as the future of private practice in our healthcare system?
I guess, what we do at Physician Performance, we do for everyone. So 30% of our physicians are in private practice across, our organization. And so we're really doing work to make sure everyone continues to exist, right? And sometimes we have to tweak that a little depending on whether it's somebody in a true private practice or at the academic faculty practice, which is also independent. They aren't owned by the hospitals. They're an independent group, a pretty large one, but independent. And so, we're always trying to find ways, again, across all our providers to make things more efficient for you. So we talked a little in the beginning, what does physician performance do? There are other things that we didn't talk about. 3 times a month, we send out a newsletter to our practices. We try to keep it concise and things that are very pertinent to practices so that, and we send it to the doctors and their office managers. I think more the office managers are reading it. But it says things like, did you know that there's a prior auth changing at Blue Cross Blue Shield? Here's what you need to do. Here's a link to the source. Did you know that the state is now requiring that your office goes in and checks your provider information in CAQH every 90 days? That's a new regulation from the state. Here's how you do it. So we try to put together information that helps them run their practices more efficiently. We also have a group purchasing agreement with Yankee Alliance. That's group purchasing organizations band together and create discounts at a really large level. And so your practice, I think you're subscribed, Dennis, but could go in, subscribe with Yankee Alliance. You don't have to change any of your vendor relationships, but if those vendors are part of Yankee Alliance, maybe you had a 5% discount before, now you have a 15% discount. So they're little incremental things, but they're all hopefully adding up to create a better financial situation for your group. And again, I think for private practices, it's the advocacy that we have at the state level, at the federal level, for things that are really going to impact your groups, I think pretty hard. Think about telehealth, right, at a small practice level. But we can also talk within the system. So if you come to me and say, Deb, every time I send my patients to X, Y, and Z, or this ED, or they get inpatient in their discharge, like nobody ever sends me a communication. We can go in and figure out why that's happening, right? Maybe it's your fax number in some system got deleted.
Yeah, they're
right?
sending it to my
Something
old
easy
office
like that.
like 8 years ago or something.
That's right. Or maybe it's something like some program that used to occur at one of the hospitals isn't there anymore. And they just didn't notify you. And so we're that glue that can help make the machine run a little easier.
That's good. That's great to hear. Those things are so important because the thing about independent practices is they have to be financially viable. And
Absolutely.
when the large, and of course the larger practices, the hospital-based practices, they have to be viable too. But there is a difference. A lot of hospitals can play the long game. They can take a loss, say on a primary care practice, because they know if they play their cards right, they can make it up on the back end with the specialists in the hospital network as large. They can look at primary care as like a referral mill, frankly, and they can, they can get their GIs fed, their surgeons fed, their ENTs fed, and they're profitable, and the loss on the primary care is worth it. If you're a private primary care practice, you just have to be financially viable pretty much on your own. And it is tough. It is challenging.
Yeah.
So all those little things add up. They add up so
That's
much.
right.
And it really is the difference. Our profit margins are not huge. They're not huge. They are narrow. And there are months where we are close to taking a loss. There are months where we come in and we are at a loss. It depends on a few factors. So we have to really, really take every advantage we can get to stay open.
Yes.
And at the end of the day, we're doing a lot of good work. So we got to do what we got to do to keep the doors open,
Absolutely. The other piece, Dennis, that we provide for our practices, again, for everyone, but I think to your point, it impacts independent private practices more, is if the health plans, again, somehow delete your record or, delete something and suddenly you're not getting paid for things you should be getting paid for. We're in there advocating for you and clearing through the pathway to get you back, to a point where you're getting paid again, and we make sure that they reprocess your claims correctly. These things happen at the health plans. I'm not saying it's intentional, but
No, it
it's
does.
hard as a solo person to just call 1-800 health plan and be like,
Oh,
could you fix my claim?
who has the
And
time? And who has the
no,
time? And your office
no,
staff is already overwhelmed,
that's right.
especially you just can't do it. So that
That's right.
stuff is appreciated. I mean, we had something
That's
like
right.
that happen to us in February where one week of our billing didn't get submitted. And it was just an administrative error, like an oversight. No one really to blame, just an oversight. And
Yep.
I'm like, why are we losing so much money in March? Late March, we're not bringing in revenue, and we
Right.
lost quite a bit of money in March, all because of one little administrative error. So that's
all it takes.
narrow difference, right?
Yep.
One little thing, and it can really affect how the office runs.
Yep.
All right, anything else you want to tell us about physician performance or anything else before we let you go? This has really been great. It's been wonderful to connect and to hear all the great work you guys are doing.
So I guess I would end with, what I see out there on the horizon that people should be thinking about. So there's a lot of things, never mind what's happening right now. There's a lot of things coming at you guys, right? So there's a lot of decisions that are happening at the state and federal level. Some are just responses, but, ACA coverage. I just read this morning a case that's being talked about at the Supreme Court regarding private insurance companies not having to cover certain cost-free preventive services anymore.
Yeah.
If that goes through, that is a huge change for your patients. So that cancer screening that used to have no copay will now have a copay, which, Dennis, that means a big chunk of your patients can't afford that and won't have them done.
That's right.
That's a huge change. So there's all these sort of decisions that are outside of your control that are going to be impacting. We talked about physician access, the aging of the population. Again, this morning I saw an NIH, there's because of the NIH grant uncertainties, that is going to affect the impending physician shortage because many people are not going to be there anymore.
Right.
And then the adequacy of the work force levels, right? Your APPs, your techs, your medical assistants, SNF staff, those are challenging positions to fill. That is all impacting your patients and how you're able to deliver care to them. So, there's a lot of things kind of looming out there, and those are the things we keep our eye on as to how can we, again, have an impact for our practices.
Yeah, and I'll put one other thing on your radar. I don't know if you saw the front page of the Globe today, but weight loss drugs to lose coverage. One of the stories we talked about last episode of this podcast was how much money Blue Cross and Harvard Pilgrim lost last year on GLP-1s like Ozempic. And now a few weeks later, story in the Globe, they're not covering them for non-diabetic patients anymore. I mean, that is going to create so much work and disruption to our office if that happens. So that's a big one. We're going to talk about that after you're gone and in the news, but that's a big deal.
Yeah, it's a double-edged sword, right? It's huge because Blue Cross is not covering it. It's also huge because if you look at the cost increases by type of care, the biggest thing, I was listening to a Division of Insurance webinar, the biggest piece impacting this almost double-digit increase in healthcare costs are GLP-1s.
I believe it 100%. And you know what though? GLP-1s will save the healthcare system money, but it takes a long time in the long run. And that's the thing we always kind of run into, this battle between short-term interest that the insurance companies are clearly focused on and long-term interest, which clearly benefits the system and all of us, and that this GLP thing is like literally the textbook model.
If there were one insurance plan, and I'm not advocating for universal coverage, I'm just making a point. If there was one health plan, that long-term would be okay.
Yeah.
because that person would stay in that health plan and that health plan would get the benefit. The problem is employers switch their insurance coverage every 1 to 2 to 3 years. So
Right.
if you're Blue Cross, you say, why am I going to invest in a long-term solution when this person could be covered by Harvard Pilgrim next?
Exactly. And insurance companies are, the way the system is set up, their focus is on being viable from year to year. That's the reality. And oftentimes from
Right.
quarter to quarter, and quarter to quarter. And so like, to tell them, oh, this is going to benefit someone 5, 10, 15, 20 years from now, that becomes a hard sell. And in my career, I feel like they'll take any plausible deniability at that point to not pay for those things, or oftentimes they will, because, if the long-term benefits aren't crystal clear, they're going to shy away from paying for some of this stuff.
Yeah. And you can appreciate their perspective, right?
Yeah.
You can
It's their
appreciate
purpose.
that perspective. Yep.
Right. And it's easy to, we all get frustrated at the insurance companies, and it's easy to throw rocks at them, but at the same time, they are in an impossible position in this system, right? Super expensive treatments, lots of patients, everything's going up. They're facing the same challenges the rest of us are facing with inflation and rising costs for everything. And they're trying to stay viable and take care of a lot of people. So there's no easy answers.
If there were easy answers, Dennis, I wouldn't have a job. So
yes. And maybe I'd be Reg. No, I'm just kidding. All right. Well, listen, we don't want to take up any more of your time. Thank you so much for making the time. I do want to take this opportunity to invite you to my office, because I feel like you haven't been in a couple years. So I want you to come.
Well, I need to come visit.
Come visit sometime, and we'll reintroduce you to our staff and show you how we're doing things at my primary care office.
Great. Well, it was nice to be able to spend time talking with you about these issues. They're important for more people to understand in greater detail.
It's what drives healthcare. It's as much a part of it as, like I said at the beginning, as much a part of what we do as the actual science and medicine.
Thank you so much.
Thank you, Deb. Have a great morning. Great talking to you.
Take care.
Bye-bye. All right. Well, that was great. Thank you so much, Deb, for a wonderful interview. She knows so much about healthcare. She really does just amazing work for all the practices that she works with, and certainly tremendous benefit to our practice.
It's the best guest you've had yet, with apologies to other guests. You know what? They've all been great.
Thank you. Yeah. Well, thank you. Yeah, we've been very lucky to have terrific guests, and Deb certainly adds to that for sure. All right, let's get to In the News, Dave, because there is a lot of things that I want to talk about. There have been some really interesting, crazy stories in the world of medicine since we last recorded a few weeks ago, and I do want to start with this weight loss drugs to lose coverage that we just discussed with Deb. I know we just kind of touched on this, but this is a big story. It is the top story in the Globe today. I had my itinerary of things I was going to talk about today, and then I got my paper and looked at the front page of the Globe today. I'm like, we got to talk about this first, because basically, headline from today, Boston Globe, the state's largest commercial health insurer, Blue Cross Blue Shield, will stop covering popular class of prescription drugs for weight loss effective January 1st, citing soaring costs that are overwhelming insurers and employers. Under this new policy, BCBS will cover the meds when they're prescribed for diabetes, but not for obesity. This is earth-shattering. I have a lot of patients that are on these medications for obesity.
You predicted this very news.
I did.
Yeah, I mean, because we were talking about how widespread the use of Ozempic and other meds are, and you were suggesting that this isn't going to hold because of the cost of the meds.
Yeah, I mean,
here we go.
Something had to be done. I shouldn't be surprised. I'm a little surprised how quick it happened and how decisive it is, because, I mean, we have hundreds. I think we probably have a couple hundred people that take these medicines for weight loss in my office. I mean, people come in, they're very popular. Saying that they're not getting coverage, like we just talked about with Deb, these are good medicines for people and they benefit people. It's good for people to lose weight clinically. That has health benefits to them. A lot of these people are ticking time bombs for heart disease, and getting them on these medicines that we know lowers the rate of cardiovascular disease is huge for them. So
it's not a vanity drug.
It's not. It's not always a vanity drug.
It's not, I guess it can be, right?
It can be it can be, and there are people that get it that probably don't really need it. But I'm thinking of like, there are a lot of patients that come into my office and they have multiple risk factors for heart disease, but they've never had a stroke or heart attack. Well, heart disease doesn't happen overnight. It takes decades to develop. And I am 100% sure this person that has high blood pressure, high cholesterol, smoked tobacco, borderline diabetic, physically inactive, overweight, I'm 100% sure that if I put a catheter into that person's coronary arteries, they would have considerable plaque in those arteries. But they just haven't had that stroke or heart attack yet. Okay, you could have heart disease for decades before you have a stroke or heart attack. So these individuals, I really try to identify clinically and put them on GLP-1s, even if it's for quote unquote obesity, because I know what it's really doing is it's lowering their rate of heart problems. Like we talked about with Charlie Dow, the cardiologist, when he was here a few episodes ago. And now it's going to be really hard to get those patients those medications, and that's really unfortunate.
Yeah, it's so widespread that anytime I have friends who I hadn't seen for a while, and I compliment them on how they look great. And if they're close with me, they'll say, "Oh yeah, Ozempic. It's a miracle drug." So I hear what you're saying. I mean, I think maybe some of the critics would say, this is akin to getting a nose job. But as you say, if it makes people healthier, then this is what medicine is for.
Well, Wegovy specifically has an FDA-approved indication for secondary prevention of cardiovascular disease in non-diabetics. So the article doesn't make clear whether that will also be covered. So if I have people that have had heart attacks and strokes, and I'm giving them GLP-1s because we have FDA approval that it will lower the rates of those, will those still get covered? I hope so, because I think those medicines are critical. That's not just nose jobs. That's not just vanity. That's, of course, that's lowering someone's rate of another heart attack by 35%. That's life-saving.
Yeah.
Anyways, we talk a lot about the GLP-1s, but it is really the cutting edge of medicine at this point. Okay, this is another spicy topic. I did a little reel on this on our Facebook page this week. I wanted to bring it up on the actual podcast. Use of antidepressant medication linked to substantial increase in risk of sudden cardiac death. This was data presented at the European Society of Cardiology a few weeks ago on March 31st, linking antidepressant use with sudden cardiac death. I still can't find, if you watch my reel on the Modern Medicine Facebook page, I said I can't find the actual paper, and I still can't find the actual paper for this. So I don't know how well done this study was done. But it is concerning. It is concerning that these medicines are being linked with sudden cardiac death. I don't know if this is a real association, a real causal association, or if it's just white noise because of all the confounding things that people that have mental health problems experience, like diabetes, higher rates, and physical inactivity, and socioeconomic challenges. All those things are linked with heart disease too. So I don't know if this is real, but this is something that should make us raise an eyebrow to how we hand out antidepressant medications.
Does it specify which antidepressants we're talking about?
Great question. And again, because the paper is not out there yet, this was just data presented at the conference, it does not specify which ones. It just says antidepressant medications, but the associations were strong. They were strong, 2.5, and there was a dose-response relationship in the data. If you took antidepressant for 1 to 5 years, you had a 1.56 increased chance of sudden cardiac death. If you took for more than 6 years, it went up to 2.2.
Now, is sudden cardiac death rare, extremely rare?
Not really.
Oh, okay.
Not really. I
so
mean,
this could affect a lot of people. I mean, I talked about a lot of people being on Ozempic. There are probably even more people on antidepressants.
I mean, I think there's a couple 100,000 cases of sudden cardiac death every year in this country.
Okay.
So it's really not rare.
So yeah, the study finds that if you use them for 1 to 5 years, which most people, if you use them, you're going to use them for 1 to 5 years.
Yeah.
Had a 56%. I'm sorry if you quoted that actual number. Higher risk of sudden cardiac death. So that's a lot of people. That's in the hundreds of thousands possibly.
And a lot of these people are young. And in these associations, they looked at them. They did mention that they looked at them based on different strata of age, and it held up through even younger people having these higher risks. So that's a little concerning too. I wouldn't stop taking these medicines. I mean, certainly you shouldn't do anything without talking to your doctor, right? Because there's always the pros and cons of everything. And this study is not, I think, well done enough to make people to really change the game. You know, again, without having actually read the actual paper, just from what I see from the data, I don't think it's been it's convincing and conclusive enough, but it makes you raise an eyebrow for sure.
Yeah. I mean, I think most experts would agree with you not to all of a sudden abandon the drug, which is the potential downside of a study like this, because some people panic when they see any kind of news on the internet. Oh my God, the study just said this. I'm not going to drink coffee anymore or something. But there are also legitimate dangers to abruptly going off your meds for depression, right?
Totally.
So,
and I mean, and it's funny because the reason I saw this study is because I think it showed up in my news feed on maybe it was CNN or Yahoo or some major news outlet, that just basically said antidepressant medication linked to sudden cardiac death. So if you're a non-medically trained person that doesn't understand the depth and complexity of how these things tease out and why this might not be even any cause for concern, it could be, we don't know yet. But if you just see that, it does create a culture of misinformation, right? It's not as cut and dry. Oh, my Lexapro is going to make me drop dead. No, it's really not that simple. It's really not that simple. But to a lot of people, they're going to see those headlines and just read it and freak out and maybe stop their meds, maybe stop medication they really need for their mental health. It's not good for your health, your mortality, your cardiovascular health to have severe, untreated, uncontrolled depression either. That's not good, right? There's definite risk to that, including mortality, morbidity, everything. So we don't know where that safe line lies yet. It'll
be interesting to see if they come out with the specifics of this study, because so far everything I'm looking at is just what you saw. They're just calling them antidepressants. Generally, we don't know what kind of drugs they are. So
right.
I hope it's not a hoax.
I don't think it was a hoax, but but you have to remember, really bad studies get published every day in really great medical journals. And it's really hard to conduct a scientific study. It's really hard if you really think about it, right? Like, how long does it take for someone to develop sudden cardiac death? How long do you have to follow someone? Decades? So prospective studies are really hard to do. So you got to do retrospective studies. That means you're looking at old data. In this case, it looks like they did something called a case control study, where they started with the outcome and then they went back through data and tried to find evidence of the exposure, antidepressant use in their insurance records. I mean, that's pretty reliable, but there are a lot of challenges just going backwards, just intrinsically going backwards for anything. So you don't really know what this is about. And it's presumptuous to jump to conclusions, because you stop your med, maybe your depression gets worse, and there's nothing, that's not good either.
Amen.
All right, let's talk about, this came out right after we recorded last, and it really hit close to home for me, because, and I think any doctor, because we deal with this all the time. This is an article from the Globe, March 17, 2025. Partners and brothers, after a big donor sought care at Dana-Farber doctor, things ran awry. This is a story of a man named Mark Cohen, who is a patient that had multiple myeloma, which is a kind of blood cancer. And for 10 years, he got really concierge level care from an oncologist at Dana-Farber, a world-renowned oncologist named Dr. Kenneth Anderson, who really is one of the best in the world at what he does. And there was emails, there was texts, weekends, nights, holidays. Nothing was off limits in terms of the access to Dr. Anderson that Mr. Cohen got. I should mention Mr. Cohen was on the board at Dana-Farber, which is what allowed him this amazing access. And after this patient unfortunately passed away, the patient's brother is now suing the doctor, saying that he didn't keep adequate medical records of the care that he provided to Mr. Cohen. And I mean, you talk about no good deed going unpunished. This guy gave concierge level care, this oncologist, to this unfortunate gentleman that, frankly, I mean, look at thousands of people get diagnosed with multiple myeloma in this country every year, and they're not getting access to their oncologist like this generally. This guy did, because he was on that board. And to go back and get sued about that because you didn't keep a record, it's a lesson to all of us, right? Because we're all being constantly asked to do favors for people. I am asked to do favors for people every day of my life. People calling me on my first personal phone saying I need X, Y, or Z, or I have X, Y, or Z wrong with them. And do you know what I've learned over the years, David? That only except in the most extreme cases where it's like a true emergency, that I really need to funnel these people back into the proper channels
Right.
through my office.
Yeah.
Because otherwise it gets messy, it gets confusing. I don't have a record. 8 months from now, oh, remember you gave me Augmentin for my sinuses and now I have that diarrhea and I'm wondering, well, no, I don't. I remember that. And there's no note written about it. So there's no record of it, right? That's terrible medical care. So this story is a lesson, first of all, to all physicians that there is a method to the madness of a way a medical office works, and we got to try and stay inside those proper channels when we can.
Interesting. Your take is obviously really good advice. This like a trap for the unwary for the physician, but to someone sort of outside of it like me, I say I feel for the doctor. Yeah. The doctor was probably going out of his way and I think definitely going out of his way. He was acquainted with this patient. They might have been very good friends for all we can tell, right? But it was this sort of casual thing. And I wonder if the doctor in the back of his mind thought, well, I'm going to, send every last email, every last text. I might not keep all the records, but, this is someone I know. It's not like this person is going to sue me.
Right.
And of course, what happens?
Right.
Yeah.
I tell my staff this all the time because it's like, yeah, everyone's friendly and nice until something goes wrong.
Yeah.
And something bad happens. And then it's all hands on deck. You never know how people are going to react to the loss of a loved one, to a bill that they're not expecting, to anything like any unexpected news. You never know how quickly those quote unquote friendships and favor seekers that can wash away in a second. So everything, and it's just good medical care too, to keep a record and to keep everything in the proper channels.
Sure.
So I push everything in, even for my mother calls me and I'll be like, I think I have UTI. Okay, I got to write a note, Mom. I got to write it. I got to put you in for a telehealth visit and write a note. I don't have to bill it, but I have to write the note because if I don't do that, it's not good medical care. And I do feel bad for the oncologist too, because trust me, he's not the only one that does this. We all do this. We all do this.
Well, let's not forget that we don't know apparently from this report what whether there was actual negligence or not. Now, I guess what they're saying is there's negligence in and of itself and not keeping proper records.
That's what they're saying.
Okay, but all right.
but
I have a law degree, and I don't want to throw lawyers under the bus, but I'd really like to know: does this suit really have merit, given that we don't know whether he died of COVID apparently.
Right.
And so was his death really avoidable if the medical records have been properly kept? I don't know.
No. Honestly, first of all, the care for multiple myeloma has revolutionized in the last 5 years. It's a different disease than it used to be because it used to be tough. This guy, when he was diagnosed, I think it was sometime maybe 15 years from the time of diagnosis to the time of death. And to live 15 years with multiple myeloma from the early 2000s to 2022, that's not a bad outcome at that time. I think now you're seeing more and more people living long like that and maybe even longer with it because the treatment's gotten so much better. But for the time he got it, he had a pretty good outcome in the grand scheme of things.
Yeah.
So it's tough. It sounds like he got great care from a doctor that was totally invested and committed and literally giving his all his personal time and the story actually notes weekends, holidays, everything, and just to get burned by that, that is tough. So it's a lesson for all doctors out there. Keep it in the proper channels. That's the right way to do it. You can still give people great care. Okay, next one. This is a great one too that I think you're going to be interested in. 17 factors affect your risk for dementia, as a study suggests. So this was a CNN story from a few weeks ago, Friday, April 4th. I like this story, and I'm going to tell you why. Because when you look at these 17 factors, most of them are lifestyle related. And in my experience, there is a disconnect between the perception around what causes dementia. We had Dr. Napoli in a few episodes ago to talk about dementia and the treatment of dementia, which is revolutionized and will continue to revolutionize. Most people think of dementia as a genetic disease, something that just happens to you because of your genes. That's not what the science tells us. The science is telling us that dementia is very much a lifestyle-related disease for the vast, vast majority of people who get it. And what this study showed, you look at these 17 factors, let me read some of them to you. You tell me if they sound familiar. Blood pressure, body mass index, kidney disease,
blood sugar, total cholesterol, alcohol use, diet, hearing loss, pain, physical activity, sense of purpose in life, sleep quality, smoking, social engagement, stress, cognitive activity, and depression.
Low social engagement, right? So going along with lack of purpose. So it seems like some of them are generally just good health habits for long life. Some of them are common sense.
That's
right. But then but I wouldn't necessarily have thought of the mental health ones, which that's interesting as well.
I mean, this is the thing about this study is it's not the only study that's shown a strong association between dementia and sort of social engagement and sort of these mental health type things. This is showing up in other places. So it is important. That's why, in Dedham, we just built a senior center, right? And most towns have it. That's important for people, that older adults staying engaged and having socialization and getting out into the world is really important.
Yeah, and let's face it, people who are retired and in a weakened state. I mean, both my parents are in their 80s, and my dad especially certainly doesn't get around like he used to. Left to his own devices, he might just sit and watch baseball games all day instead of, so it's all, needless to say, I'm not the expert. Dementia is all about the mind, so you can see how not keeping that muscle exercised would
stimulate it,
right? And it's not just watching TV; it's talking to people,
right?
It's maybe even like sort of problem solving. Or I wonder do you recommend any kind of I hesitate to even suggest it, but like an app? There are apps that are supposed to keep your brain fresh.
None of those have been clinically proven.
Okay.
But as a general rule, I do think things that are like brain games or puzzles, playing an instrument, reading, Sudoku, crossword, whatever. I do recommend all that. I think all of it's good.
Yeah.
And I think you look at studies like this, they don't specifically say, this app or this thing, but in general, that stuff appears to be protective against dementia.
Yeah.
And I think Sal Napoli, when he was here, we asked him that, and I think he said that at some point too.
I gotta imagine it's part of the puzzle for sure.
The other thing about some of these 17 things that protect dementia, look how many of them are related to like obesity and lifestyle and healthy diet, your blood pressure, your body weight. That is a huge piece of it too. And the whole insulin resistance and inflammation and that whole thing we don't really understand, but that is a big piece of the dementia, just like it is for a lot of the other illnesses we deal with.
Mm-hmm.
All right, let's talk next about, this is a great one I found, March 14, 2025, again, European Society of Cardiology. This is a study they came out with, resuscitation in out-of-hospital cardiac arrest. It's how quickly it's done rather than who does it. So they did a study on CPR. CPR, we all know what it is. If you've taken a CPR class recently, they've gotten away from the breaths. It's really now about the compressions. And what they showed is that every 5-minute delay in return of circulation through CPR came with a 38% increased risk of death when people had a witnessed cardiac arrest out in the community. And what really matters with CPR is how quickly it is initiated. And that is what this study showed. So if you are someone out there, you don't have to be a medically trained person, you don't have to be a doctor or a nurse. Take a CPR class and be ready to give CPR if you need to give CPR. If someone goes down, start doing those compressions because that's what saves lives.
Yeah, just 5 minutes. I mean, and that's we've all had the moment where, you're in like a banquet hall or something and somebody faints, or maybe it's, it's 99 degrees out that day and somebody faints from the heat. And there's always a few moments of confusion and is anybody a doctor? And, it's just scary to think that what happens in those next 5 minutes makes a big difference.
It's life or death. I mean, look at the Damar Hamlin thing, right? And that great outcome. Why did Damar Hamlin have a great outcome? Because everything was right there. If people had cardiac arrest in places where you had defibrillators and people that knew how to do CPR and had that access to care, a lot more people would survive. Yeah.
I mean, with Hamlin, he even with all that care, that he just barely survived, right?
Barely.
I mean, yeah.
And you look at the data, the outcomes data on people in his situation, not a lot of people survive. But I think one of the reasons he did is because, the NFL stadium is a place where there are a lot of trained people that were ready to do what they had to do. If more people dropped in situations like that, more people would survive. I really believe that.
Yeah. To think that he played football last year.
I know.
It's amazing.
I never thought he would play again.
Yeah.
I think it's crazy, but I mean, God bless him.
Yeah.
He wanted to do it,
Right.
and he did it. Okay. And then last one, this is a big one for me. The health benefits of a Mediterranean diet, according to science. A couple big papers have come out in the last few weeks about further health benefits of the Mediterranean diet. David, what kind of diet do you eat?
I try to go high protein, low carb. I'm not always perfect, I admit, but and I try to do multiple doses of protein per day. But I have to say I love Mediterranean food because it to me it's one of the few categories of food that mostly healthy, high protein, and it tastes good.
Absolutely. And I'm Lebanese,
Sure.
and I love Arabic food. Grew up on it. It's my favorite kind of food to eat. It's not always healthy in reality.
Yep.
The Mediterranean diet takes its roots in the population-based observation from a long time ago, going back like a century, that people that lived in the countries of the Mediterranean basin lived longer and healthier than other parts of the world. And then scientists and epidemiologists looking back and studying why that was. And what they realized is that there are some fundamental differences in the macronutrient composition of a Mediterranean plate from, say, a traditional Western diet that really look on different kinds of oils, quality of grains, more emphasis on fruits and vegetables, more lean meats as opposed to fatty meats, and that those basic things led to better cardiovascular and other health outcomes, including cancer and everything. So now we've studied it for a century, and we know what a good Mediterranean diet entails. And I would encourage everyone to look that up and discuss it with a nutritionist if you need to, because the health benefits of a Mediterranean diet are massive and they're real.
Greek salad, souvlaki, maybe some falafel in there.
Well,
I've only been to Greece once, but more than once while I was there, we got the souvlaki, and even like the takeout souvlaki was so incredible and fresh compared to anything you get back here.
I bet. But a lot of that stuff is like really junk food, right? Like a real Mediterranean diet is probably going to be different than like the popular Mediterranean diet. Like I know just from my friends and family in Lebanese, I mean, a lot of what we consider Lebanese food is really not very healthy for you.
Okay.
The true at the core, yes, but like the westernized, 21st century version of popular Lebanese food, there's a lot of food in there that probably isn't very good for you. Some of it, yes, is good. Tabbouleh and maybe if the falafel isn't fried in oil, if it's baked, that's good for you.
I can't imagine falafel's ever really good for you.
Right, exactly.
I mean, it's just a fried ball of chickpeas. So, but no, I take it we're talking more about things like salmon, other kinds of fish, lean meats, maybe some lamb,
fruits and veggies, olives, all the unsaturated fats in olive oil, very good for your heart. Very good, cardioprotective. So great thing. I can't believe I made it. I think this is the 5th episode or the 4th episode. I can't believe I made it this far without talking about the Mediterranean diet, because the people that know me know I'm obsessed with it. So we're going to talk more about it in future episodes, but suffice it to say, literature keeps pumping out to show that it's healthy. In fact, my residency program director is someone that has studied the Mediterranean diet extensively, and I think he would be a great guest for future episodes. So I'm going to have to reach out and see if I can get him. He's a world-renowned researcher, by the way, in firefighter health.
Well,
and
maybe
safety.
we can have some samples of some meals here in the studio.
He does a big thing. He used to do a big thing every year at Harvard School of Public Health, where he would do like a huge Mediterranean type meal with all like healthy Mediterranean, like legit healthy Mediterranean food. He's Greek. So, Greek, it was unbelievable. So
yeah. Well, let me ask you one quick question before we move on. So, like, There's a place I like to go in, I guess it's in Norwood or Walpole, called the Feisty Greek.
Yes.
And
Know the owners.
Oh, you do?
I went to high school with them.
oh, come on, really? Okay, so I love that place. I get takeout from there all the time.
Great place.
And I'm telling myself that no matter what I order, it's likely going to be healthier than at least Chipotle or God forbid KFC or something like that. Healthier than most, right? But are you saying even that is not necessarily?
It's probably healthier than most, but even that is not necessarily true. And I think what you need to do is learn about the Mediterranean diet, learn about the macronutrient composition of a traditional Mediterranean plate, and then you will be able to find those foods in Greek or Arabic restaurants if you want them. They will be there, and there will also be the traditional westernized junk foods versions mixed in. There is nothing worse for you than our Lebanese desserts. Lebanese desserts.
What's an example of a Lebanese?
Like batlawi or baklava.
Oh,
right?
baklava.
They're called
Love
batlawi
Sure.
in Lebanese.
Okay. Yeah.
And everything is like flaky, phyllo dough, covered in sugar and syrup,
Yeah.
and with powdered sugar and melted cheeses and they're so bad for you. They're so good. They're so damn good.
Yeah.
3 bites is like 600 calories.
So moderation.
Exactly.
But I do love baklava.
On Sunday, my aunt Fadia, she makes these cookies called raibi, and they're just like these thick, dense, like butter cookies. They're butter and flour, and like literally this big. They probably have about 800 calories in each one because it's just butter and flour and sugar. My 3-year-old loves them. She loves them. She'll go over and she'll just start piling them in. And there's nothing healthy about that.
Right.
But they're delicious. So I'll be tempted on Sunday to try and avoid the Arabic desserts because they are very good.
Oh, yeah.
All right, man. And then very quickly, one more last thing I wanted to bring up to you. We're going to end it on this.
Okay.
This is the clinical case of the week. And this is a very simple one, a very common one, but I think it has a nice take-home message here, which is I had a 65-year-old guy come into my office who has really suffered with chronic back pain for a long, long time. And he has tried everything. He does not want to take narcotics, which is a good idea because if you look at the literature on the use of narcotic for long-term management of chronic non-cancer pain, I would also not want to take them because they are not safe or effective. They do have a few FDA approvals, but they're not great medicines for that purpose, which is why they are so problematic. And of course, they have significant risks of addiction and other health risks, frankly, that make them not desirable. So this gentleman does not want to take them. He's tried everything else with minimal effectiveness. We decided to compromise and give him tramadol, which is a synthetic, very weak narcotic that can take the edge off pain, but it's certainly not a true opiate in the sense of the how we see them, and which he had been taking as needed a couple times a week to help him just get through his difficult days. He came into my office this week and he said, I've heard about this new non-opioid treatment for pain that I want to try called Journevax. Have you heard about this medication?
I have not, no.
So this is a drug just released to the market, FDA approved in January, and it is only FDA approved for acute short-term management of pain. It is not a NSAID, so it's not like an ibuprofen, and it is not a narcotic. It works by blocking chemical signals and pain signaling pathways involving sodium channels in the peripheral nervous system, and it stops pain signals before they reach the brain. The studies on this medicine showed it to be highly, highly effective and without any known risk of addiction. We'll see if that continues over time, but it does not sedate. It does not change the way people feel, supposedly, and it isn't really thought to have abuse potential, which is different than obviously narcotics, and even some of the other drugs we use like gabapentin and Neurontin have some abuse potential, believe it or not. So this, we think, does not have any. So this is a game-changing medicine, and I said to this patient, I said, look, I'm going to write your note the way that I think I need to write your note to get your insurance to cover this, because this guy's been through the ringer. It's legit. I didn't do anything dishonest or anything like that. Like, this guy's tried everything. He's out of options and he's suffering. So we wrote the note. I said, I don't think you're going to get it. I said, I'd be shocked if you get it, but let's give it a try. So we put it out there. He got it covered. He got it paid for. He picked it up. He took it, and it worked for him.
How about that?
It worked for him. And it literally reduced him from using tramadol maybe 2 times a day, or, maybe say 10 to 15 times a week, to maybe, I think the first 2 weeks he's used it a couple times, like 2 or 3 times a week. So reduced his tramadol use, made him more comfortable, improved his quality of life. He's sleeping better. He's feeling better, all because of this medicine. Now, it's not approved for long-term use. It's only approved for short-term use. So are most narcotics, by the way. And we give those out to people for long-term use all the time. So I don't know if they're going to keep paying for this or not. We'll see. But this is a game-changing medicine.
Well, and good for you for suggesting it.
Yeah.
And I mean, do you often tell people, this is it might not be covered, but it's worth us trying? In other words,
yes.
Okay.
Yeah, I explained to people that. Yeah, I explained to people, look, this is so actually the full backstory is he came to me and said I wanted to try it, but now that the full backstory is the visit before that, I had mentioned this to him. I said, maybe this is something we could try. We'll see how you do this month. And he came back a month later and said, I did terrible. I really want to try it.
Yep.
So that was the story. So I did suggest it to him. I mean, we have to give people, we don't want to send people on a dead end street. Right. We don't want to give them a cutting edge new drug or give them a sample of it and have them work for them great for a week, and then we can't keep them on it. We're just setting them up for problems. Can't stay on it. Maybe they have to wean off their old medicine and then wean back on it. It's not good care. So we don't want to give people medicines we don't think we're going to be able to get approved. Right. Because it's a road to nowhere. But in this case, he really had no other options. And how can it hurt? So we gave it to him, and it works great. And the side effect profile for this medicines is very good, we think. It takes time. It takes time to see what the side effects are. But I think these could be real game changers.
Well, good for you. Good. We end on a happy note.
Yeah, the cutting edge. In my office, you get the cutting edge of modern. That's why we call it the modern medicine. You get the cutting edge in my office. But I'm excited for this, and I'm excited to see how. And I'm hoping that the FDA approvals will move towards more long-term use, and that the insurance companies will pay for it for people, so that we can start, maybe if it's appropriate and the data says it's a good idea, maybe we can even start to get people off narcotics and get them on this stuff instead.
Indeed.
All right, man. Anything else you want to add before we wrap up this? Awesome. Did we do the non-medicine topic of the week? You got anything?
We didn't.
I didn't think. All right. Well, let's do this. Yep. Default. We just talked about this. Patriots number 4 pick in the draft on Thursday night. Who are they taking?
I think they're going to take Campbell, the offensive lineman, even though signals out of the team seem to be that they. I don't know. I feel like I always get my hopes up for the draft. It's going to be some exciting pick, some brand new shiny toy, and then it isn't. So that's what I think is going to happen. What I hope is going to happen is maybe there's a trade mixed in there.
Yeah.
Maybe we pick up an actual rostered wide receiver from another team. Like, that would be cool. I don't know. What do you think?
I don't think they should take Campbell, because I think there's too many good tackles that are going to be available in the early second or late first round. I think they're going to have the opportunity to trade back into that late first round if they want to. So I would rather they take a chance on one of those guys. The guy Simmons from Ohio State, Connerty from Oregon, Trapillo from BC. All those guys are going to be around then. That's where I think you get your tackle. I think you take the best player available that's not a running back with that 4 pick. And to me, that's Tyler Warren, the tight end out of Penn State, from what I've seen in all the lists. So that's who I want to take. Give Drake May a weapon. He can help with the receiving. He can help with the blocking. He can help with the running game. And I think he's an elite level talent, which is really what they need. They need elite talent.
Yeah, well, before we started recording, you were mentioning to me that look at the Chiefs' success with Kelsey over the years. Look at the Patriots with Gronk over the years.
Yeah.
And it is they're rare. The uber tight ends, right? I mean, you can get a decent one. We've got a decent one, Hunter Henry.
Yep.
But he's no Gronk. He's no game changer.
He's no game changer.
Nice to have one.
And look at even some on a smaller scale, like some of the really good offenses right now, they really have a good tight end. Like look at Detroit with Laporta and even the Eagles. They got that, the guy's name escapes me now, but I think we have to change the way we look at the tight end position in this passing game heavy NFL. If you can get a versatile tight end that's like a 5th wide receiver or 4th wide receiver out there, that's I think a field tilter. So that's why I like Warren.
Dallas Goedert on the Eagles.
Dallas Goedert, that's right. Yeah.
Thank you, ChatGPT.
Thank you, ChatGPT is, ChatGPT will be replacing me in my office and doing this podcast
We're gonna have to
within
talk
the
about
next
that.
5 years. Yeah. We should talk about that. All right, listen, thank you everyone that took the time to listen to this episode of the Modern Medicine Podcast. We hope you enjoyed it. Find us on Facebook, find us on YouTube, subscribe to our channel, like us, follow us. I've been doing short videos lately, so I'm going to keep doing those as well. So you'll get the best up-to-date medicine information in the world of medicine. Have a great week, a happy Passover, and a happy Easter to everyone.